introduction first. VLP's webinar focus for October is Medicare. Because there is so much to learn and know about Medicare, we hosted 2 webinars this month to cover that topic. 2 weeks ago, our speaker presented on Medicare basics. Today, she's going to focus on Medicare's annual enrollment period. For those of you that don't know me, my name is Sarah Avila, and I'm a financial advisor here at VLP. If you're attending one of our webinars for the first time, welcome, and thank you for joining us. For those returning, welcome back, and thank you for your continued trust in our firm. VLP is a financial planning and wealth management firm located in Vienna, Virginia. We work with clients both locally and nationwide. Our goal is to be a trusted partner to the individuals, families, and businesses that we serve. In the last 25 years, we've grown from a 2-person firm to a team of 19 and counting, which includes 7 certified financial planners, 5 accredited investment fiduciaries, 2 chartered financial analysts, and a certified divorce financial analyst. Today, our advisors have a collective experience of over 100 years, and we celebrate being recognized by the Washingtonian and Northern Virginia Magazine as top advisors, an honor we have held for over a decade. We are excited to be joined by today's presenter, Emily O'Halloran. Emily is the Executive Director at MP Group, formerly known as Medicare Portal. Prior to finding her mission in Medicare, Emily spent years educating and training individuals and communities on how to understand and access other government programs. Today, applying this experience, Emily and her team of licensed insurance agents collaborate to develop a positive Medicare enrollment experience for their clients and to maintain those relationships over time as their clients' Medicare needs evolve. A few housekeeping items. We ask that you keep your lines muted and videos off while the presenter is speaking to minimize background noise and other distractions. This presentation does not generally take the full hour. Usually it's about 45 to 50 minutes. So we typically have some time at the end for questions. You can ask your questions either by unmuting your line at the end of the presentation or typing your question in the chat box. Feel free to type the questions at any time throughout the presentation. They'll be addressed by Emily at the end, or if there happens to be a good stopping point in the middle, then she would stop and answer questions in the middle of the presentation. At this time, I'll turn the presentation over to our speaker, Emily O'Halloran. Emily, please go ahead.
Thank you, Sarah, and good to see so many familiar names this morning and a few from a couple of weeks ago. For those that I haven't spoken with before, thank you for joining us today. And Sarah, certainly thank you for having us again this month. So we love talking about Medicare, and this is an important month to really focus on it. So as Sarah said, we are a group of independent Medicare insurance agents. We're based in Tyson's Corner, but we're working throughout the region and throughout the U.S. actually. Our focus is Medicare education, just like we're doing today. And then we also provide enrollment and lifetime support to current and future Medicare beneficiaries that we work with. So this is our map that shows our current states that we serve. We're changing this map all the time, updating it. Hopefully one day it will all be filled in, but this is where we are right now. So I have been working with Medicare insurance for just under 5 years, almost at 5 years in February, and really passionate about it. Worked with hundreds of Medicare beneficiaries and brought 2 of my 4 kids on board as well. So it's a family affair, and we really do enjoy working with people and sharing our Medicare knowledge and learning more along the way. As we'll talk about later today, there are always things changing with Medicare, and it's really important to stay up to date with that. And that is one of my personal areas of interest, is not just what Medicare looks like today, but what it will look like in the future. So what we're going to cover today, it looks like a lot. We're going to spend a very short period of time just hitting a couple of bullet points on what the parts of Medicare are. So think of this as a Medicare refresher. For those of you who joined us 2 weeks ago, it will recall a lot of the things that we talked about in Medicare Basics. For those of you who are on Medicare, it may be something that is just a helpful reminder of what the parts are, how they work together, how they don't. And then from there, we'll get into what is the annual enrollment period, then who is eligible to make changes during this time period. What are the things that can change in your benefits that you currently have if you're on Medicare, therefore causing you to potentially need a change at this time of year? We'll talk about where you can find those changes and then what changes are available to you to make at this time. I'm going to share some changes in Medicare as a whole. We do, very excited to say, have the numbers for 2024 now. So that could be helpful for those of you who are on Medicare and wondering how your expenses are going to change next year. We'll talk about how to avoid some mistakes with Medicare at this time of year. Also, fraud we want to be careful of all year, every year, and some of the ways that you can do that, how we help working with clients, and then hope to have a lot of time for your questions and answers, which certainly please drop those in the Q&A feature and we'll keep an eye on that. I'm sorry, not the Q&A, the chat. We'll keep an eye on that and see if there are any that we need to stop and address as we go. So really quickly, refresher on Medicare. As many of you know, there are 4 official parts of Medicare, and that is a key word, not to be confused with Medigap plans. They are plans A through N in Medigap, but the 4 parts of Medicare are A, B, C, and D. Part A is what is called your hospital coverage, and you want to think of that as your inpatient care. So Part A is going to cover inpatient hospital services as well as inpatient rehab or nursing care, home health care, and hospice. It is typically premium free for those who have earned enough credits for premium free Part A, which is going to be most Medicare beneficiaries. But for people who have not, it is available at a specific premium based on your work credits, if you have any, and that's something that if it applies to you, we can help you with. Part B is called medical coverage. You want to think of it as your outpatient care. So this is going to be your coverage that will handle your claims for seeing doctors in outpatient visits, whether it's primary care or specialists. Part B will take care of your labs and radiology, preventive care. Part B does have a cost, a monthly premium, and that will vary based on your income. So a lot of you may be familiar with that. And that is something that we can help you with offline if you would like to learn more about the IRMA charges, which are the income-related charges for Medicare Part B. The base premium for 2024 is going to be $174.70 per month. Most people will pay that. About 8% of Medicare beneficiaries will pay more than that based on the IRMA amounts. Then you have Part C. So Part C refers to what are also known as Medicare Advantage plans. These are your all-in-one plans that fully replace your Part A and B benefits and typically include your prescription drug care. These are the plans that may offer some additional benefits beyond those offered by Original Medicare. They're entirely provided by private insurance companies. They're replacing your Medicare benefits. Medicare or CMS is paying these private insurance companies a fixed monthly amount to cover the Medicare member. The plan designs include HMOs, PPOs, point of service, private fee-for-service, and MSAs, but the most common are going to be HMOs and lately PPOs. Part C plans often have a monthly premium. Some will be as low as $0. It will vary from plan to plan, from market to market, and they will all have a fixed out-of-pocket maximum. So that's a number past which the plan member is no longer responsible for their costs. That has a ceiling that is set each year by Medicare, and then the Medicare Advantage plans can set their maximum out-of-pocket lower than that Medicare ceiling. So it will vary from plan to plan, but with Part C Medicare Advantage plans, every member does have a fixed maximum out-of-pocket. Part D, this is your Medicare prescription drug coverage. Part D is offered by private insurance companies exclusively. They're contracted with Medicare to offer these Part D plans. This is for your self-administered outpatient prescriptions. So medications that are received in a healthcare setting other than at the pharmacy where you may receive a vaccination. Other prescriptions that you receive in a doctor's office will typically fall under Part B, your outpatient care. If you are enrolled in a Medicare supplement plan, which will be working as a secondary payer after Part A and Part B, you would have a standalone prescription drug plan. The medications covered by the Part D plan will be listed on the plan's formulary, and that will vary from plan to plan. Part D plans do include an additional amount based on income. Again, that's about 8% of Medicare beneficiaries who will pay these IRMA charges, but there is an additional charge on your Part D as well as your Part B if your income falls in those ranges. And there is a penalty for not having Medicare Part D coverage. So that is something that hits some people. And if you're here today, you have not enrolled in Part D in the past and need to stop that penalty from increasing, we're going to talk about how this is your time to do that. So Medigap plans I mentioned, this is a synonym for Medicare supplement. So Medicare supplement and Medigap mean the same thing. These are not Advantage plans. These are private secondary insurance designed to pay after Medicare Part A and B pay. So you must have Parts A and B to enroll. And these are the plans that will take care of the majority of your out-of-pocket costs from A and B. They're offered entirely by private insurance companies with plans. So that word, not to be confused with part, but plans A through N will be the standardized Medicare guidelines defining what Medicare supplement you have. Medigap premiums vary quite a bit from state to state. Even some states, large states, will have regions with different rates. They'll vary based on your age, your gender, tobacco use, household size. Some states have more strict regulation where they change eligibility requirements that can also have an impact on the rates in those states. So the difference between Maryland and Virginia, for example, is pretty significant. So there's a lot going on there with the Medicare supplements. And this is just a side-by-side comparison of how original Medicare with a Medigap or Medicare supplement plan compares to having a Medicare Advantage plan. And I think this is an important slide to review as we talk about the changes that you can make this time of year, because it's really important to understand the difference between these two types of Medicare, option 1 and option 2, before you make a change. If you're currently enrolled and you're considering a change to your coverage, making sure that all of the distinctions between these two types of coverage are really solid is important. So let's talk about this piece by piece. So when you have original Medicare and you've added a Medicare supplement, that supplement is your secondary payer after Medicare A and B pay. When you're on an Advantage plan, that plan exclusively, that private insurance company is receiving and paying all of your claims. Original Medicare cannot pay on your claims while you're enrolled in a Medicare Advantage plan. With original Medicare Parts A and B plus a Medicare supplement, you can see any healthcare provider anywhere in the country that accepts Medicare. So that's going to be over 96% of all healthcare providers in the country. With Medicare Advantage plans, these are going to be managed care plans, as I said, typically HMOs or PPOs with a defined network of providers. Sometimes referrals will be required, and you'll have more instances of prior authorization being required under this managed care model. When you have an HMO Medicare Advantage plan, you may not go outside of the network. If you do, you'll be responsible for the full cost of the care. With a PPO, you can see any doctor who accepts Medicare, original Medicare, but if you stay within your plan's network, you'll have lower cost sharing amounts. So that's the difference between an HMO and a PPO with the Advantage plans. Costs with the Medicare supplement, you're going to have a monthly premium. And as I mentioned, that's going to vary based on a number of factors. On the Medicare Advantage side, you may have a monthly premium, which can be very low or nothing, but then you'll absolutely have an maximum out-of-pocket amount for the year. With the Medicare supplement model, as I mentioned, you will need to add a separate standalone prescription drug plan. But typically the Part D coverage, the prescription coverage, will be built into a Medicare Advantage plan. There are some exceptions to that. Those plans are designed for very specific people who have other prescription drug coverage from a different government source, such as the VA or TRICARE. But others will want to focus on the Advantage plans that do have built-in prescription drug coverage if looking at Medicare Advantage. With original Medicare, your benefits are what A and B covers. So your supplement is really only going to cover your expenses that it's designed to cover as a secondary payer. It won't cover things that A and B don't cover. On the Advantage side, you will have some additional benefits, typically such as dental, vision, and hearing benefits. And then how does eligibility work? And this is something that is an important distinction this time of year. Many people think that Medicare supplements or Medigap plans participate in the annual enrollment period, that they can use this time period to change a Medicare supplement or to get a new Medicare supplement Medigap plan. And that is not the case. So these are more private. They are not a part of Medicare. That's a part of the annual enrollment period. They have limited instances of guaranteed eligibility for the applying Medicare member, such as when you first enroll in Medicare Part B, or a few other limited circumstances. So they are not a part of the annual enrollment period. You can apply for a Medicare supplement for the first time, or as a change from one plan to another plan, or from one company to another company any month of the year. But without a specific instance of guaranteed issue rights, it would be a medically underwritten application, which would mean that your eligibility for that supplement would be determined by your current and recent past health history. So that's a really important distinction. If that is new to you, you're not alone. Most people are not aware of that. So it's something that's a high priority for us to educate our clients about. Now, Medicare Advantage plans are open to enrollment once a year. Annual enrollment is right now, and that's what we're going to talk about next. At no point are Medicare Advantage plans medically underwritten. In other words, coverage is never based on your health status. So that is a big important distinction between Medicare supplements and Advantage plans. So I'm going to take a pause. I see one question in the chat, and I just want to make sure that we're either about to get to it or that we take a pause to do it. Any thoughts on the FEP Medicare prescription drug program? Should I keep it or opt out? That sounds like a question that we should tackle offline. It's not something that I'm very familiar with. So, Joan, if you want to address that over email, we can talk about that, but I'm not very familiar with that. So I'm sorry that I don't have a great answer for that one. All right.
Emily, there's another question. I think he sent it directly to me, but I think he meant to send it to you or to the group. He says, are vaccines covered under Medicare Part B or Medicare Part D?
So if you receive the vaccine at a pharmacy, it's typically going to be under Part D. If you receive the vaccine at your doctor's office, it would fall under Part B. And some of them are interchangeable. So some of them, it's perfectly fine for your primary care provider or specialist to bill Part B if they give you the vaccine in their office. Some of them you'll get at the pharmacy. And one of the things, I'll mention it again later, but we'll mention it now, one of the improvements in Medicare that began this year is that there are no longer any out-of-pocket costs for Medicare members for the vaccines that are recommended for Medicare members. So previously, people had to spend a lot out of pocket for things like shingles vaccines and other recommended vaccines, but that has been eliminated, whether you receive it in the doctor's office or at a pharmacy. So that often just comes down to what's most convenient for you. But you shouldn't be dealing with any out-of-pocket costs in either case if it is a recommended vaccine. All right, so let's talk about what this annual enrollment period is, because I've already identified at least one thing that you can't do. So let's focus on what you can do this time of year. One of the common misconceptions when people hear that it's the open enrollment or the Medicare annual enrollment period is that people who are turning 65 soon, whether it's in the next couple of months or early next year, they often think, oh, I'm getting close to 65. I need to sign up for Medicare right now. It's the annual enrollment period. That is not the case. Everyone who becomes eligible for Medicare at their 65th birthday has their own initial enrollment period. What happens this time of year is for current Medicare beneficiaries. So anyone who is not yet enrolled in Medicare, this is not a time period that applies to you. You will have your own time period based on either your 65th birthday or your retirement or both. But right now, what we're doing is we are looking at plan changes that are available for current Medicare members. This annual enrollment period has the same dates every year, regardless of when those dates fall. So it's very easy to remember. It is always October 15th through December 7th, and the start of the new coverage that you will have selected during that time period, if you select anything, is always January 1st. One of the things that a lot of people don't know about the annual enrollment period is it's the only Medicare enrollment period where you are allowed to make multiple elections. So this means that if you sign up for a plan today, you can change your mind and sign up for 10, 30, 40 more plans between now and December 7th. And the last election that you make on December 7th is the plan that you'll begin on January 1st. Not that I recommend that anyone is going to do that, but that is something that is different from any other Medicare enrollment period. So who is eligible to make these changes? Well, as we've said, it's people who are currently enrolled in Medicare. So specifically, you're enrolled in A and B and perhaps a supplement and a Part D, or you're enrolled in A and B, but you've then also enrolled in Part C to replace your A and B benefits. Those are folks who can make a change at this time. And there we go. Okay. All right. So what we want to look at first is who might need to make a change during this time period. So just because you're eligible to make a change, another common misconception is that you should or you must. And that is absolutely not necessarily the case. What we encourage everyone to do is to just review, to take a look at it, because you may or may not need to make a change. What you need to be reviewing and looking at is how might the benefits that you have had thus far changed going into the next year. Whenever I talk to someone and we're looking at how their current either Advantage plan or their standalone prescription plan is changing from one year to the next, I tend to see a lot of surprise at how many things can change drastically. And I'm not surprised, but the plan members are. So you really want to look at all of the mail that is coming from your plan and watching for those changes, because you might be someone who's very surprised with a change that you see. So some of the things that will change every year are going to be to parts A and B. So I already shared with you that new Medicare Part B monthly premium, but beyond that, the out-of-pocket amounts for both parts A and B have gone up. So you're going to see those changes to your parts A and B benefits and your monthly premium. But then if you have an Advantage plan, a Part C plan, or a standalone drug plan, you may see changes in those benefits as well. You may see changes to the monthly premium that can be significant. Also changes to copays, even for a medication you've been filling all year, you could see a drastic change to the copay or coinsurance, as well as to the deductible. On the Advantage plans, you might see a change in the out-of-pocket maximum. Every year, the ceiling for that maximum is raised by Medicare itself, typically. So your plan has the ability to raise the out-of-pocket maximum. And you can also see changes in your plan's network of providers, whether it's bringing on a lot of new providers or maybe losing that connection or contract with a certain health system or group and providers leaving the plan network. So all of these things are things to be paying attention to, but where can you find these changes? So your first place to be watching, and everyone who is with us today who is on Medicare already and has either a Part C plan or a Part D plan should have received something called an ANOC, or an annual notice of change. And what this is a letter from your Part C Advantage plan or your Part D prescription drug plan that typically arrives in late September. If you're set up to receive your correspondence from your plan electronically, you would have had either an email or a message in your portal. If you're set up to receive paper documents, you should have received this in the mail. Typically, it's on a different colored piece of paper so that it stands out. And the goal is to identify all of those changes that I mentioned on the previous screen, if there are some that are occurring. Changes to the premium, to the out-of-pocket amount, to different tiers, to the formulary. So that is something that everyone should have received if you're on one of those plans. If you haven't, you can access it on your plan's website or by calling the member services number on the back of your card. But you definitely want to make sure that you've received it and that you've taken a look at it to see if there's anything significant. Okay, so what changes can you make if you see something that is significant that's going to impact you? So these are the 6 types of benefit changes that you can make during the annual enrollment period. The first one is that if you're currently enrolled in a Part C Medicare Advantage plan, you can change to a different Medicare Advantage plan. If you have original Medicare, whether you do or do not have a supplement, you can enroll in a Medicare Advantage plan at this time. If you have Medicare Advantage and you would like to return to original Medicare, you can disenroll from your Advantage plan at this time. Typically, that involves signing up for a standalone prescription drug plan. Doing so ends your Advantage plan and puts you back in original Medicare. Now, this is a really important note to consider under item 3 here. You can easily return to original Medicare Parts A and B, but original Medicare has unlimited out-of-pocket expenses. So if you are going to be an original Medicare, you want to seriously consider having a Medicare supplement in place as the secondary payer so that you are not responsible for those unlimited out-of-pocket expenses. And just remember that the Medicare supplement is something that you will have to apply for and qualify for based on your health status. So item number 3 on this list is something that is not necessarily a simple solution or available to everyone. It's an example of a situation where we would want you to reach out to us and we would really guide you through this so that there isn't an issue with losing the Advantage plan and perhaps not being able to secure the supplement. So that one's the tricky one. I think we should change that to red maybe. If you are in a Part D plan, a standalone prescription plan, you can change your prescription plan. or if you didn't enroll when you first started Medicare, you can enroll in one now, which will stop you from accumulating any further late enrollment penalty. Because you can't enroll in one throughout the year. So if you're someone who didn't enroll in prescription drug coverage and you need to add it, definitely want to take advantage of this opportunity because it won't come around until this time next year. And if you are in Part D, and this is a very limited circumstance here, the last item on the screen, a handful of people will have a reason for opting out of their Part D plan, and this is the time to do that. I'll give you one example of who might need to do that. I've talked to a few folks who are federal retirees who have Medicare A, and some people have A and B, plus their federal retiree plan. Those plans include prescription drug coverage, but sometimes people get confused and they also add a Medicare Part D plan, and that's a recipe for disaster. And you want to get out of that Part D plan. So this would be the time to disenroll if something like that had happened to you. There's a few other instances where it would be warranted, but mostly we're talking about people who want to try an Advantage plan for the first time, switch to a new one if they've already been in one, or if they have a standalone Part D plan, to change their Part D plan because there's been a change either in their medications or in the coverage of their current plan. So I'm going to take a second to just look at the questions in the chat and see if we need to hit something now or in just a moment. Hi, Nancy. One of the participants has an Advantage plan through their former employer, and that would be a group Advantage plan. And just like a publicly available Advantage plan, it may have changes each year. And those changes would be communicated by the insurance company. They may or may not have been something that the employer requested. It might just be changes to the insurance, but those can have annual changes just like an Advantage plan that's available to the general public. And they should have told you about the change as well. If it is an Advantage plan based on you having A and B, then that would be something that you should be looking for, certainly. Okay, and then I see a question from Cynthia, and that would be a question that would be best answered offline. So typically, the federal employees do not have to add Part B, but usually the state employees do have to have A and B. So I'm a little surprised that he does not have A and B, but it might have something to do with age or if he's still working. So that would be a question to send me an email and we can talk about that offline. Okay, yes, and Nancy said she did not get her annual notice of change, so definitely call. We all know mail gets lost. I think I get 5 pieces a week for my neighbors. So things like that happen, but it is available either on the website or by calling member services. So moving on, so let's talk about some of the changes that are occurring to Medicare as a whole. And these are things that I think will be very interesting for a few people. So this slide we'll spend a few minutes on because if you haven't yet seen this slide from working with me or someone on my team, we really like this slide to explain how Medicare Part D works. These 4 blue boxes are the coverage stages under Medicare Part B. And the coverage stages themselves are the same from one year to the next, and they're the same whether under an Advantage plan as built-in Part D or as a standalone Part D. What changes from year to year is what happens within each of these coverage stages. So this is one of the reasons that people find the prescription drug portion of Medicare the most confusing. What you have is progression through these 4 coverage stages throughout the calendar year. And what happens, especially if you have some medications that have a higher retail cost, is you'll see a little bit of a roller coaster in your out-of-pocket amounts. So if you've experienced that, but you've never seen this slide before, I hope that this helps put a visual to that ever-changing out-of-pocket cost that you have run into. So for all Part D, the first coverage stage is the deductible. Now, if your plan has a deductible and some do not, you will pay 100% of the retail drug cost until you meet that deductible. For 2024, the maximum deductible is $545. Most plans will have that deductible. Some will have a lower or no deductible, and most plans will exempt their low tier or generic, typically medications, from the deductible. From that deductible stage, you go into the initial coverage stage, and this is where your plan is paying for the medication primarily, with you participating at either a fixed copay or a coinsurance, which is a percentage of the retail cost. Now, this number that's in bold, the $5,030, is the total retail cost of filled medication for 2024 that will tip you into the coverage gap. This is up from last year, as it was from the year before that, and so on. So the threshold on the actual retail cost, not what you pay, but what you and mostly the plan are paying to cover the medication, is higher than it has been, and hitting that threshold is what tips people into the often confusing coverage gap that is more commonly known as the donut hole. So many people will not go into the donut hole. If you have an expensive medication, you may, and it could happen at any point. I have clients who have some very costly medications, and they will jump from the first coverage stage to the last the first time they fill their medication. It's entirely based on the retail cost of the medication that's filled. So this looks a little bit different for everyone based on what you're filling. But when someone gets into the coverage gap, you're paying 25% of the retail cost of the medication. Sometimes you're actually paying less in the coverage gap than you were in the initial coverage stage. The reason for that is that many medications, especially more expensive medications, will have a coinsurance of 30, 33, 40, even 50%. So in that initial coverage stage, you might be paying up to 50% of the retail cost of the medication, and you are someone who is going to be jumping for joy when you get into the coverage gap because your medication cost will go down. The reason the donut hole sounds so scary and ominous is that 11 and 12 years ago, the out-of-pocket cost sharing was 50%. And we had far fewer high-cost medications at that time. So not many people were paying a lot for their medications out of pocket until they reached that threshold. And then the coverage gap was much more punishing than it is now. So the donut hole is not always bad. It can be good. It just depends on what you're filling. Now, the biggest change going from 2023 into 2024 is that once you and your plan and manufacturer's discounts have reached the threshold of $8,000, it's actually called the true out-of-pocket limit, which I think they need to rename it because it makes people think that's what I've paid out of my pocket. And that's not the case. It's what you've paid, what your plan has paid, what the manufacturer's paid. When you reach this threshold of 8,000, which is higher than it was last year, you will then tip into the catastrophic coverage stage. Starting in 2024, there is no more cost sharing in this catastrophic coverage stage. This is an enormous change. We have had people, as I mentioned, who have gone from the deductible into catastrophic coverage in 1 month. And in years past, they have then been responsible for 5% of the retail cost of the medication. That could still amount to tens of thousands of dollars for certain medications. Now that that has been eliminated, we're going to see really a major relief for people on very, very costly life-saving medications. So that is probably the biggest change, this 0% If you or someone you know takes something extremely expensive, this is going to very significantly impact your out-of-pocket cost on prescription drugs next year. Other changes that were included in the Inflation Reduction Act that specifically impact Part D, we've actually seen this throughout 2023. All of the plans have to have certain covered insulin products at $35 or less. Not every insulin product will be $30 or $35 or less, but some on each formulary will be. And then this is another big change you'll see right here down at the bottom. Our first step to getting Part D costs down was this elimination of the 5%, taking it down to 0 for out-of-pocket in the catastrophic coverage stage. We are scheduled to have a maximum out-of-pocket of $2,000 for everyone starting in 2025. So stay tuned for more on that. Next year at this time, this slide is going to look really different in order to accommodate this upcoming change. So if you found this slide a little bit confusing, please do not be upset about that. This is something that is a lot more complicated than I would like it to be. This is the hardest part of Medicare to understand. I'm happy to talk with anyone about this offline. It's something where if you have expensive medications, you're experiencing this, and I think it's important for you to understand why the cost of your medications varies throughout the year. This is what's happening. So this is just an example of how that elimination of the 5%, the taking it down to 0, will change the cost of a medication. So Revlimid is often used for multiple myeloma. So someone who is taking this self-administered medication, who in 2023 would have spent $12,800 of their own money, so that is their out-of-pocket cost, will spend $3,300 approximately on that medication in 2024. So you can imagine how significant that is. And that's just one example of a medication that will be impacted by this change. Okay, so some other things that are changing. You may know someone who qualifies for what's called extra help, or also known as the low income subsidy. And this is a program that in the past has had a tiered level of benefits. So they've really eliminated that partial program, those tiers, and you have full benefits for anyone whose income is up to 150% of the federal poverty limit. And with this program, if you know someone who qualifies, they will have specifically their prescription drug coverage with no deductible, no premiums, and significantly lower copays. So the Part A deductible for 2024 is going to be $1,632, up from $1,600 this year. Part B's deductible next year will be easy to remember. In 2024, it's $240. It was $226 this year. So we're seeing a medical cost trend of about 6 to 7% increase, and that is something that is reflected in these premium increases. Another thing that will impact premium increases will be Medicare's approval of extremely expensive medications that receive FDA approval. And an example of that is this medication Leqembi for Alzheimer's. So we have this here to kind of demonstrate how medication costs impact your monthly premium. The estimate is that coverage for this medication under Medicare represents about $5 of your monthly premiums next year. So it's just an example of how the whole program comes together and covers the things that it covers. Oops, I think I skipped a slide. All right, so we talked about some changes that are coming further down the road, like the maximum out-of-pocket of $2,000 in 2025. Many of you may have heard about the new ability for Medicare to negotiate drug prices. So that has been occurring. The first 10 medications, which you can see right here, you're going to recognize all of these from commercials on TV. All of these have been negotiated this year and going into next year. The impact of that will be seen starting in 2026. Then there is a new list of 10 drugs that will be negotiated each year with up to 20 by 2029. So these changes should also have an impact on the out-of-pocket costs paid by Medicare members for these brand name, currently very expensive medications. If you know, you know. If you take one, you know what I mean. Other things to keep an eye on or just listen for, especially as we go into an election year, Medicare tends to be a topic of conversation in politics, and various things that are discussed will be increasing the Medicare entry age or decreasing it. So you can think about how that might impact you if you're on Medicare or soon to be. Other things that could occur to help fund the Medicare program. And that's what's going on as our population skews more towards over 65 than under 65. We have to figure out how to pay for all of this. And one of the things that might occur is those income adjustments being lowered so that they impact more people. So I mentioned that it's about 8% of people who pay more for Medicare because of their incomes. 2 years ago, it was 5%. So that might be something where we start seeing 15% or more pay more for Medicare based on that means tested adjustment. We could see a percentage in what you pay when you have a higher income increased. We could see an increase in the base premium for everyone. So these are all things that have been discussed, and we watch for these things as they are up for consideration from one year to the next. Another big issue that is something that people are looking at is Medicare does not currently cover long-term care, specifically custodial care. So remember that Medicare is medical insurance, it's health insurance. It does not cover custodial care. And a lot of people just don't understand that distinction. And so what happens is we have people who do need custodial long-term care who wind up having to pay out of pocket or potentially qualify for Medicaid. Medicaid is separate from Medicare, and it's designed for people with lower incomes. But an interesting fact that I recently learned is that 71% of Medicaid funding throughout the country is covering people on long-term care. So it's becoming a ballooning issue that I think will be potentially addressed on the Medicare landscape at some point. But keep that in mind. Certainly, be clear that custodial care is not covered under Medicare, and that it's something that people will be questioning as it becomes a need in their lives or a loved one's life. Okay, so how do you avoid making mistakes this time of year? Well, certainly we want everyone to be aware of all of the ads and calls, those 800 numbers, the mailers that you get, the mailers that try to look like it's a government postcard or letter, but we know it's not. Promising more benefits or indicating that you're missing out on something, that's a pretty common tactic. It's just something to be aware of, that these are marketing efforts designed to get you to look at other Medicare options that may or may not be right for you or needed. Remember that you'll never be called directly by either the IRS or Social Security or any other government agency. So if someone tells you that they're calling from Medicare, they absolutely are not. Under no circumstances should you share your Medicare, or if you have Medicaid, or if a family member does, never share that with someone who calls you. If you initiate a call to an organization and they need that number, or an agent or a health plan, it's fine to give it. They will need it to take an enrollment. But if someone reaches out to you and you provide that number, you can be enrolled in coverage unintentionally. It helps to be on the National Do Not Call Registry. Many of you may already be, and I hope you're seeing some impact from that. So just remember that the overall messaging at this time of year tends to make people feel like this is the time to make a change and you have to do it. So I hope that the things that we talked about today made it a little bit more clear about why you might want to consider a change, but that you don't have to if everything is working and going smoothly and there are no changes to your benefits that are going to impact you. If you have a Medicare supplement, a Medicare Advantage plan, or a Part D plan right now, and you make no changes and you continue to pay the premium, you will be enrolled in all of that coverage at the start of next year. So you do not have to take any action. And sometimes it can feel like everyone is telling you that you do. You're keeping your coverage if you don't make a change. Often you'll get the sense that there's something out there that you're missing out on. Plans with no cost, and they're giving you money back, and they're paying your utilities and your rent and groceries. And just keep in mind that what is featured on ads is often going to be something that only a very limited number of people, for the things that I just mentioned, typically defined by an income need, would qualify for those things that you're hearing about. So just keep that in mind, and know that it is something that you're going to hear that isn't necessarily applicable to you. So as a general rule, as I said, you do not have to make any changes. It's just a question of whether or not any would be advisable. And as a general rule, I think we all know if it sounds too good to be true, then it probably is. So the details are what matter. You're not going to get those details in a little mailer or a ad on TV. So you really want to be careful and investigate anything that you hear about and you're curious to learn more about. You absolutely want to dig into the details. So we work with our current clients. We can work with new clients. We'll help take a look at any annual notice of change updates to your coverage and assess whether or not your current coverage is still a good fit for you. I have countless conversations where nothing needs to be changed, and that's just fine. So that's how we work with our clients, is we want to make sure that you're in the coverage that's right for you and that we answer as many questions as we can. We are limited on answering certain questions for plans where we're not contracted with that plan or if we're not the agent, but we do everything we can to answer as many questions as possible. Things like whether or not your providers are still in the network, or looking at other options if you need to consider other options or would like to talk about something different. The goal is to make sure that your coverage meets both your financial needs and your medical needs, not just for the year ahead, but the long term, because we all have to think about the coverage that we want to have 10, 15, and 20 years from now, when some things are not always available to you. So we call our process the PATH process. We help people prepare to enroll in Medicare, help people apply for A and B, their supplements, Advantage, and drug plans. We try to teach people how it all works together, just like we did today, and help throughout the year as needed. And especially this time of year, we're really busy talking to every single one of our clients if we can, to make sure everyone is all set for next year. These are some of the resources that we have on our website. We're also on social media. We encourage people to be very familiar with the Social Security website and the Medicare website and the Medicare What's Covered app. If you're not currently a client or might not be at any point, but just want to receive our quarterly newsletter, you can sign up for that on our website. And as Sarah mentioned, until October 1st, we were Medicare Portal. Medicare passed a bunch of new rules that are designed to protect Medicare members from third-party marketing. They don't want anyone to be confused and think that we are Medicare, so we had to change our name to MP Group. Everything else about our organization is the same. We were Medicare Portal, now it's MP Group. So that's all you need to know there. Okay, let me see what questions we have in the chat, but we certainly can do unmute if people want to do that. Nancy is asking about defining custodial care. So in a nursing home, for example, you may have a lot of custodial care and you may have some care that is medical. So it depends on whether or not it's provided by a skilled health professional. And specifically for Medicare, the coverage is going to be tied to a recent hospitalization and potentially surgery or injury. So there has to be a medical need for that care and that, sorry, I'm not thinking of the right word. If you're in nursing care, a portion of it may be covered by Medicare based on a recent medical need, but your actual just custodial care, taking care of you and your activities of daily living, is not medical, and so it's not going to be billable to Medicare. So it's usually a mixture, but then as people get older, often it's just entirely custodial care that someone is receiving in that nursing home facility. And memory care is not covered by Medicare, so that would be self-pay or something that you might have a long-term care plan for. And as I mentioned, many people are using Medicaid later in life to have that nursing care or custodial care covered. Let's see. All right. Thank you, Nancy. Good to see you. Does anyone have a question that they just want to unmute and ask? And I'll put my contact information up here. I'm watching the chats, so feel free to type something in here. Yes, this is a very good point that Maria is making. So even if you do qualify for Medicaid to cover your long-term care needs, you're going to have to be working with a nursing facility that has an allocated spot for you, and not every that there's a long wait typically in most states for those spots. So it is it's tricky. We don't work with long-term care. We think Medicare is enough to focus on. So that would be something that I think Sarah or whoever you work with at VLP either could advise you on the right financial planning for long-term care, and or put you in touch with someone that they prefer to work with on that topic. But it is something that catches a lot of people by surprise. I think most people just kind of connect it to Medicare, and it really isn't connected, unfortunately. Thank you, Scott.
Right, Emily, I don't see any additional questions, but I want to thank everybody for attending this month's webinar. And of course, a big thank you to Emily O'Halloran for presenting. If you have additional questions about your Medicare options, please do reach out to Emily, and of course, follow up with your VLP advisor. We hope to see you again at our future webinars. As a reminder, you're always welcome to forward our webinar registration links to family or friends who you think would benefit from the webinar topic. They don't have to be a VLP client to join the webinar. Thank you all again for joining, and hope you have a wonderful day, and hope to see you next time. Bye.
Thank you, Sarah. Thank you, everyone. Have a great day.